Welcome. We have four wonderful speakers lined up today, which you're aware of. But I just want to also highlight that we've had this series now for 3 years. This is our third year. And so if one of the specialties that you're interested in is not listed this year, you can go back to the series from the past years and you might be able to see a few speakers that you find interesting. This QR code takes you to our YouTube channel, and all of these sessions are recorded. As noted earlier, only the presentations are recorded. We don't record the Q&A. But if you have questions for a specific speaker, you can reach out to me and I can try my best to connect you with the appropriate physician. I'd also encourage you to just follow the channel in general for all of our workshops. For those interested in PhD as well, we have PhDs as well. We have workshops on those, and we have workshops on a number of other STEM-related careers, as well as summer programs and post-bac programs. And the LinkedIn group or page is where you will see all of our upcoming events. But importantly, that's where we also post opportunities, internships, scholarships, deadlines for upcoming programs, etc. So I encourage you to go to our LinkedIn page and just follow so that you can get all the up-to-date information. All right, so we're gonna get started, and our first speaker today will be Dr. Markeiya Jasper. And so I'm gonna hand over to her. She'll do her own introduction because she'll do it much better than I would.
Thank you so much, Danielle. So good to actually see you. Really excited to actually talk to, all these pre-med hopefuls or, just anyone who wants a career, obviously in healthcare, in general. But am I able to have control of these, Danielle, or will you control them?
I'll
Okay.
progress them for you. Yeah.
Oh, awesome. Okay. So, for me, just a little bit, about myself. I think that might have been, is this my first slide, Danielle?
Yes.
Okay, awesome. The biggest thing is, everyone really wants to know, like, how or why do we come to this decision of, why medicine or, why OBGYN? Honestly, really for me, I did have a non-traditional pathway, which I'll talk about, a little bit later, but for me, I was just inspired by, daily interactions with patients, kind of realizing, and after doing a lot of shadowing and, following some mentors, really just seeing how you really make a difference in an individual lives, like person by person by person. So that's where, when I talk about, just seeing those tangible outcomes. So I start with you from the beginning of your pregnancy, and then we have a really good pregnancy and we have a great baby in the end. So, you actually can see those things. It's really tangible. I was also really passionate, about women's health. I love surgery. So, as you see, when you'll shadow and you do a lot of clinical, rotations, you'll really pick up on what it is that you really like, versus, not really like. And so those were the things that, I knew that I really enjoyed. And so OBGYN kind of really helps putting it all together. So you get that mix of surgery and procedures, and then you get clinical work. And then also, another thing that I really like to do is kind of mentor and teach med students and residents. And so you still get to, do not only just patient advocacy, but advocacy for, underrepresented, minority students in medicine, in healthcare. And so that's something that's really important to me. So my training pathway, apologies, but I did leave off a whole degree. But I started off at Howard University. I got a bachelor's in biology and minor in chemistry. After that, I actually went to public health school. So I went to Tulane School of Public Health in New Orleans. So I did not actually, go straight through. So I wasn't a traditional applicant. And so a lot of times, sometimes you're like, I don't really know what I want to do, like, and doing these like gap years and things like that. And so what I did was I actually went to public health school. And then after that, I actually worked for the Centers for Disease Control for a couple of years, as an epidemiologist prior to actually going to medical school, in my, home state of Louisiana. I'm originally from Louisiana. And so coming back to, our state school, was really nice for me because obviously I was at home for medical school, but also at the same time, that patient population was very, very, just in need. It's a very, very high risk patient population, whether you're doing obstetrics, whether you're doing internal medicine. So definitely, I knew that I was going to get the breadth of experience that I actually wanted. And then I stayed for residency. So I stayed and did my residency at LSU in New Orleans, and I stayed on for a couple of years as an attending, kind of a hybrid attending in a private practice, but also in the academic system as well. So as an adjunct professor for the LSU School of Medicine, which I still have that professorship as well right now. So what do I do? So a day in the life of an OBGYN, it is really, really as nonstop as people believe it to be. You wake up first thing in the morning, head over to the hospital. We round on patients, inpatients that are there. Right after that, I'll do a surgery, whether it's a C-section, hysterectomy, any minor procedures. After that, I'll have clinic for a couple of hours where I might see in a half day anywhere from about 18 to about 20 or so patients. Then lunchtime, I try to slip in another procedure or surgery if I can. You can't really schedule deliveries as much as you can your actual surgeries and procedures, but I tend to try to use that time wisely and do that there. Then the afternoon is my afternoon clinic where we see a couple more patients. Same thing, probably around 18 to 20 patients in a half day. And then after clinic ends, rounds that I didn't get to in the morning because a surgery kind of, took a little bit more time or something like that. If I'm able to actually deliver a patient right after clinic, that would be great. But a lot of times they come in the middle of the night. And then if you're on call, you stay at the hospital. You don't actually leave. You don't go home. So that is really, what a typical day in the life of an OBGYN looks like. So you definitely get a good variety. What are some pros and cons of OBGYNs? The pros, you just get that large variety that I talked about. You're never going to do the same thing over and over again, so that's really nice. Meaningful patient relationships. So I will see you from, your first, experience as far as coming in to say, hey, I'm getting a menstrual cycle, and all the way up until menopause where, you're no longer having a you're no longer having a menstrual cycle, so it's really nice to have those long lasting relationships, so that continuity. And then, like I mentioned before, just the opportunity to do a lot of procedures and surgeries, things that you would do outside of just sitting in a clinic. And then what are some cons? Yeah, you work a lot. Some long hours, things are just unpredictable. So you don't just get to sit in the clinic and, everything is just peachy keen. Literally somebody can call you in the middle of, an exam with a patient that, hey, I have another patient in the hospital that's ready to deliver. So, I got to go run across the hall to the hospital and go deliver a patient, and delays my clinic. So that definitely can be somewhat of a con. It is emotionally and a little, physically demanding because you really are always on the go. You're always working, you're always moving. But definitely something you can totally do. And then there's a lot of legal challenges in obstetrics for those of you who are following in the news and things like that. Women's reproductive, just like services, things like that are being cut in a lot of places, particularly where I am in the South. And in this process, though, to get to obviously med school, to get to, a challenging residency, like you're going to have some challenges. And so, the biggest thing that looks everybody in the face, the coursework, the board exams, those things, they don't really stop. The biggest thing is you really have to learn how to manage your time because you're always going to need to, know how to manage your time, especially when you're no longer studying for exams and you're actually in your office and you're practicing. Long hours, emotional challenges, work-life balance. You hear people tell you all the time, work-life balance is really, really important. Some of the ways that I kind of try to overcome those challenges is really trying to make sure you're practicing self-care, you're putting your mental health first. Those are things that really, really do matter. The things that you really enjoy, make sure you make time for those things, make sure you make time for those people. self-doubt and the imposter syndrome. You will hear a lot of us along this journey talk about that. That is something that, it doesn't really go away, but you really do, the way that you kind of overcome that is you acknowledge it. Like, that like, hey, look, these feelings are there, but you got to figure out how to reframe your thoughts and kind of really know that like, hey, you've worked really hard to be here. You really deserve to be in these rooms. And so, that's definitely something that, I've really done along the way. Of course, being a minority, being a woman in medicine, all of these things kind of really tie into that challenge of, self-doubt, imposter syndrome. And then just a few tips how to be successful, along this journey, developing those strong study habits that I tried to, that I mentioned before, really trying to figure out like if there's a certain learning style that fits for you, that's really important, whether it's flashcards, practice tests, all of those things, just find what works for you. You stay consistent and, really, really try to just put forth that effort. Prioritizing your time management. Like you are never going to go wrong with creating schedules and really helping you, from, point A to point B. But it's just like, hey, I know that I'm going to spend 2 hours on this topic, then I'm moving on. Like, really try not to get bogged down by things. And then being resilient, managing your stress, whatever it is that you need to do for your mental health, you do that. Be curious and never stop learning. Even now as an attending in practice, I at least make sure that I'm intentional about attending at least 2 to 3 conferences a year because I still have to learn, right? I want to be the best doctor that I can continue to be. And so I have to practice some evidence-based medicine. I need to know what's changing, what's going on out there. Want to make sure that you know how to communicate. That is going to be really, really important at any stage in your journey, but particularly at this undergrad stage when, you're going to have to be in interviews. You're going to have to continuously, really communicate what it is that you want because people want to know, hey, why do you want to do this job? Why do you want to be in medicine? So that becomes really important. Finding a mentor, networking, doing, programs, attending virtual programs like these are super, super important because you are never going to know who you're going to come across and you're going to say, hey, I want to reach out to that person. We will always give you our contact information and really welcome, any interesting pre-meds to just reach out if you're really interested in how can we help you. We definitely will give you whatever it is that you need. And then the last thing is really just, stay passionate. Remember why you're on this journey in the first place, right? If you kind of keep that passion alive, you say, hey, look, I know that I'm going to keep going because I truly, truly am committed to this. I mean, you are truly, truly going to get there. And that's my contact information. I'm sure it'll be available at the end as well, for anybody, but definitely please feel free to reach out.
Thank you so much, Dr. Jasper. And
Absolutely.
we're gonna jump right into the next speaker, and we'll take all of the questions at the end. So Dr. Ehmsen is up next. Thank you.
Good evening, good afternoon, everyone. It's a pleasure to be here with you this evening. So I am a genetic medicine physician, so I'm happy to tell you a little bit about my career journey and what it is that I do kind of on a day-to-day basis. So just briefly, I'm currently the chief resident for genetic medicine at Johns Hopkins Hospital, also a clinical and research postdoctoral fellow here. I recently completed my residency training in internal medicine and genetic medicine. So it was a combined residency program, which I'll talk to a little about in just a moment. And working in a laboratory that uses gene editing technology to develop new treatments for genetic disorders. Prior to where I'm now, I completed an MD PhD program here at Hopkins. And I'm originally from California. I did my undergraduate work close to home at the University of California in Irvine. And studied biology and chemistry there. Looks like there's a fellow anteater online. Very happy to see that. Hello. So yeah, in terms of how I actually became interested in genetic medicine. So I was studying chemistry and biology at UC Irvine. And I think, similar to many other undergraduate programs in our country, we're fortunate to have the opportunity to experience research firsthand. And that was something that was encouraged at my institution as well. So I joined a lab that was studying a specific type of muscle disease called facioscapulohumeral muscular dystrophy, or FSHD. I know that's quite a mouthful, but really was kind of a branch point in my kind of career goals and kind of what I was looking for in life, really. Became introduced to kind of how fulfilling research can be, especially I think when that research is focused on understanding mechanisms of human disease and trying to advance treatment for human disease. And also was a wonderful opportunity for me to experience the value of international collaboration. So, attending meetings where there were colleagues from around the world working on this condition as well, and even patients who attended these meetings and really getting to see how valuable it was to have their involvement and participation and their insights into the direction of the research. I also have several family members who have been affected by genetic disease. So a cousin who has a condition called Marfan syndrome and who unfortunately died of that condition, and a cousin who has a condition called cleidocranial dysplasia. So for all these reasons, was just really kind of inspired to pursue a career that would combine research and clinical care, especially intended towards genetic disorders. So what is genetic medicine? So this is really diagnosis, management, and really continued efforts to improve outcomes for individuals who have genetic disorders, really of all ages. So we take care of patients in the NICU, from first days of life all the way through adulthood and end of life. In terms of diagnosis, unfortunately, many genetic disorders are undiagnosed or underdiagnosed. That being despite the fact that we really have great technologies available for diagnosis. So on a day-to-day basis, a lot of our activities are involved with inpatient consults. So consults for patients who are seen in the hospital where there's concern for a potential underlying genetic etiology for their condition. So a lot of these consults will come from the neonatal intensive care unit, other specialties as well, including adult medicine services, and then seeing patients on an outpatient basis as well in kind of the general genetics clinics and more specialty clinics as well. Here in Maryland, we're also involved in receiving and interpreting all the newborn screening results that come through for the state of Maryland. So if there's a concern for an abnormal newborn screen for an infant, we will see that individual in our clinic and do some further follow-up diagnostic testing and evaluate whether they need any further management. In terms of managing these disorders, so as you can imagine, many genetic conditions require quite unique monitoring and intervention throughout their lifetimes. So really one of our most important roles is understanding kind of the natural history of specific genetic disorders and knowing what should be monitored to reduce risk of certain things over that individual's lifetime. So just as a few examples, thinking about instances where maybe a genetic condition might be associated with increased risk of certain cancers, so being sure to monitor for those particular concerns. And then in individuals where maybe there's concern for increased risk of abnormal neurodevelopmental outcomes, there are fortunately some early childhood interventions that can be put in place to help really try to improve outcomes for those individuals as well. A lot of what we do also involves risk counseling for other family members. So as you can imagine, sometimes if one person is diagnosed with the condition in a family, that has implications for other family members. So trying to ensure that those family members are also screened, diagnosed if necessary, and they receive appropriate care as well. This also includes prenatal genetic counseling and testing, in some instances, pre-implantation diagnostics. I think a very important part of what we do as well, or at least for some individuals in this field, is research. So really trying to advance our understanding of these diseases and really trying to advance therapeutics for these individuals. This could be, really working on understanding underlying basic mechanisms of disease, to working on investigating new therapies, implementing those therapies in clinical trials, and continuing to really try to understand the natural history of some of these genetic disorders. I think one thing that I wanted to really highlight was that genetic medicine is a highly multidisciplinary field. That's one thing that I love about it. So, many genetic disorders, as you can imagine, are multisystemic, so really require expertise in many different organ systems. As just one example of that, a condition called Marfan syndrome. This is a disorder of connective tissue. has multiple systemic manifestations. So from the perspective of the heart, these individuals are at risk of dilation of the aorta and dissection. Thinking about the lungs, these individuals are at risk of a condition called pneumothorax, which is collapsed lung. Thinking about the eyes, these individuals are at risk of lens dislocation, so monitoring for that, monitoring vision. In terms of orthopedics, these individuals can have a number of skeletal abnormalities, including scoliosis. And then we just heard from Dr. Jasper in terms of obstetrics as well. These individuals, women with this condition, are at high risk of aortic dissection during pregnancy and during delivery. So really kind of working multidisciplinary with many subspecialties. And that being said, even within genetic medicine, there are many subspecialties. So some individuals can do what's considered general genetics, so seeing patients kind of all comers, but there are many subspecialties with genetic medicine as well, and that includes neurogenetics, neurodevelopmental genetics, neuromuscular genetics, such as muscular dystrophies, cardiogenetics, so conditions such as the connective tissue disorders, cardiomyopathies, a whole array of specific cancer genetic syndromes that are associated with increased risk of certain hereditary cancers, reproductive endocrinology and immunology. So this is a whole kind of subspecialty subfield for helping individuals who may be at risk of issues with infertility and helping those individuals establish families if that's something they desire. And really on and on. It's quite a diverse field with many, many subspecialties. In terms of how to come into genetic medicine, so I think there are it's kind of a standard pathway to begin with. So after your undergraduate work, you would enter medical school. So this could be either pursuing an MD or Doctor of Osteopathy or an equivalent degree. And then thereafter, there's kind of two paths. So here in the United States, at least we have at least two options for combined residencies. So individuals can do what's considered an combined internal medicine and genetic medicine residency, or combined pediatrics and genetic medicine residency. And those are typically 4-year programs. And then individuals who come from other pathways, so maybe they've studied internal medicine first, or pediatrics first, or obstetrics and gynecology, neurology, many other different fields, can do what's called a categorical fellowship in genetics. So this is typically a 2-year fellowship that would specifically focus on genetic disease. And just an example of that, we have 2 individuals in our current training program, one who studied neurology first and one who came from a background in endocrinology and who are now studying genetics to really try to incorporate that component into their field. For individuals with a background in obstetrics or gynecology, there's also the options for combined maternal fetal medicine and genetics fellowships, and reproductive endocrinology and immunology genetics fellowships. And these are paths for individuals who have obviously an interest in obstetrics and gynecology, but who may also be interested in kind of more thinking about prenatal genetics, prenatal counseling, high-risk pregnancies associated with genetic disorders, and again, individuals who may be challenged with infertility issues. And then ultimately, after completing this training, most individuals will pursue national certification, and that's typically through a board exam through the American Board of Medical Genetics and Genomics. In genetic medicine, we work with many other individuals with interest in genetics as well. So I just wanted to point out genetic counseling. Genetic counselors are an integral part of our work. And genetic counselors typically would receive a master's degree from the ACGC and certification through them as well. And these individuals, again, are critical to the work that we do in genetic medicine, and working closely with families to provide counseling regarding genetic risk. There's a lot of options in genetic medicine research as well, through working at universities, hospitals, and industry. And individuals who are interested in research paths would probably consider a master's degree or a doctorate in genetics. Bioethics is also something that's important in what we do. So again, paths to that would be a master's degree or doctorate in bioethics, law, or related fields. Just wanted to touch briefly on some of the challenges that many of us might encounter. So in my own experience, just kind of initially navigating some uncertain waters and expectations. So I did come from a family that had many scientists, but no one had ever really pursued medicine. And I think, for many of us who might not have a specific role model, that can sometimes make things challenging. So, what I recommend for that is, fortunately, many universities offer resources to prepare for medical school. For example, here at the School of Public Health at Johns Hopkins, there's a specific multi-week course really focused on just helping individuals kind of navigate the application process, prepare for interviews, thinking about tests, those kinds of things. It looks like I'm about out of time, but would just echo what Dr. Jasper had mentioned as well in terms of kind of this concept of self-doubt and imposter syndrome, something that many of us will experience, I think, part of being human. But I think just important to really kind of be clear about your values and how your efforts are aligning with your values, considering a leadership course. And I think really wanted to emphasize the importance of finding mentors, especially those who've walked a similar path and can share thoughts or advice with you along your journey as well. So I will wrap it up there, and again, would be more than happy to hear from anybody if they have any questions coming up. And I apologize for going over time.
No problem. Thank you very much. And hopefully we can get to some of the things you want to discuss in the Q&A session. Up next, we have Dr. Patel, who's going to talk about urology and urologic oncology.
Thanks, Janelle. Can everyone hear me?
Yeah, very good.
Perfect. Okay. So my name is Sunil Patel. I'm one of the Urologic Oncology faculty here. So urology is a really unique and fascinating field, in my opinion. It's a surgical field of the genitourinary system, but it's often seen as a medical and surgical subspecialty, as urologic care has significant kind of medical care associated with it. So you're almost serving as part-time as a surgeon, but also as a sometimes a primary care giver for these patients, which is very unique, similar to gynecology in that regard. And the fascinating thing about urology is, though, it does cover the entire patient population. So we take care of both men and women, but also pediatric and geriatric patients. So all patients have some sort of urologic issues, and that kind of goes about in terms of the fellowships and everything that we need to do to become a urologist. So in order to become a urologist, you have to perform your undergraduate studies, do 4 years of medical school, whether that's an MD or DO. The vast majority of urologists are MDs in this country, though. Residency takes about 5 to 6 years. In the first year is usually your internship year, which includes general surgery year. And fellowships range from 1 to 2 years. And so it's a quite a long journey, but a very rewarding journey. And so getting back to that first part of urology being very diverse, because it's such a diverse field in terms of the patients that we take care of and the complexities and the diseases that we take care of, there are a lot of different subspecialties. So one can kind of look at urology in a general urologic field, which is usually people who finish residency and they're like, you know what, I want to take care of a little bit of everything. And then some of those go into general urology. So you can take care of pediatrics, adults, kind of the bread and butter urology, what we think about. So kidney stones, people with enlarged prostates, some patient men and women both who have urinary leakage, so very kind of straightforward medical issues. And then you get to the fellowships, which are female pelvic reconstruction, which is a little bit of overlap of urogynecology, and doing a little complex pelvic reconstruction, which is very fascinating and very rewarding. And then you have the trauma reconstruction, which is dealing with complex trauma of the urologic organs, but also reconstructing the male lower urinary system using complex surgeries, using muscle flaps and tissue flaps. So it's really, really interesting and fascinating surgeries. And then you have urologic oncology, which is me, where you're taking care of just cancer patients. And I'm going to get into a little bit why I chose that. And then you have endourology, which is our urologists. They use a lot of fancy gadgets, small cameras. They deal with a lot of the complex kidney stones and have a lot of new instruments that they use and lasers. Reproductive and andrology, which is doing really infertility and men's sexual health as well, and really focus on the male aspect of it in terms of the reproductive. And then you have pediatrics. So you kind of encompass every part of urology with all of those fellowships. So getting back to me, so like I think a couple other people said it on this call already, you don't really have to fit the cookie cutter and go straight from undergrad and go to medical school right away. There's different ways to do that. I was one of those people who did not know I wanted to be in medicine. I actually started off as an engineer, and then played college football and rugby, and then I actually ended up playing professional rugby overseas for 2 years. And in doing so, became fascinated with photography and was a photojournalist for some time afterwards. And then decided to come back and kind of hone in on my skill set as an engineer, and then ended up doing some work in Boston, and did my master's out there using microfluidics. And that's where I got to know a urologist over at the Brigham and Women's, and is just a very lovely guy, and our paths crossed. And he was like, you don't come off as someone who should be in a lab. You like talking to people and you like helping people. So let's figure some stuff out. So I did some research with him. I'm like, yeah, you know what? I think I want to be a doctor. And then at that point, I was like, I want to be a surgeon. And so I ended up applying to medical school, and I got in, and I stuck around and did med school and then residency. So there are different ways. You don't ever have to feel pressured into doing or if people just go through straight through 4 years of undergrad and straight into medical school, that's not necessarily the right answer. So my training was, I did, after all of the undergrad training and all the gap years, so to speak, I did 4 years of medical school at Boston University School of Medicine. I did my 5 years residency at UC San Diego. And then I did my Urologic Oncology fellowship here, which I was fortunate enough to get hired on as faculty as well. And this photo right here is just a picture of some of the surgeries we do, but a lot of people don't think of urologists. People think of urologists as helping people pee. That's come very different than what I do. That's the picture of the big two blood vessels of the body. And so men with testis cancer, we have to skeletonize that, or patients who have bad kidney cancer. So we end up doing things that I think people don't think urologists do. And so for the urologic oncology is, in my opinion, one of the most fascinating fields for a lot of reasons. So one, it focuses on adrenal cancers, kidney cancers, ureteral cancers, bladder cancers, prostate cancers, penile cancers, and testis cancers, and a lot of the complex retroperitoneal cancers. They are complex discussions and surgeries, which both keep things fascinating and interesting on a day-to-day basis. Again, probably a con as well. There's a big multidisciplinary aspect towards oncologic care. And the pros of being at Johns Hopkins is that we have very smart people from all subspecialties, so we get to collaborate. So not only do we constantly interact with medical oncology, radiation oncology, pathology, and a lot of other surgical subdivisions. I mean, I operate with gynecologic oncology, surg-onc, colorectal all the time. So it's very good to be in these systems where you're dealing with multidisciplinary teams, and you learn a lot, and patients get better care, in my opinion. There's a lot of good research opportunities. So I do a lot of basic science work in the lab, looking at environmental carcinogenesis and causes of cancer in the environment, in terms of water and food. And so we have the ability to do that. And urologic oncology is very, very research heavy in terms of your kind of practice, especially here at an academic institution. And then the other really good thing about urologic oncology is that we get longitudinal care. When I alluded to at the very beginning about almost being a pseudo primary care for these patients, I get to take a patient, diagnose them, or they come in with a diagnosis of cancer, go through all the discussion with them, and hopefully get them through that kind of tough part of their life and follow them and keep a close eye on them and see. And so there is a lot of job satisfaction in that. And I will tell you this, and this is not just for the purpose of this talk, but I truly believe I get great job satisfaction. There are long days, there are numerous days where you're tired, fatigued, but I enjoy speaking to my patients. And I think that there is a field in medicine that I think for everyone that loves that. And then the cons, long training, which we talked about, again, complex discussions and difficult decisions, and complex and long surgeries. But you got to kind of choose whatever you want to do with that. But that's a little bit about urologic oncology and why I chose it.
Thank you so much, Dr. Patel. And we're on to our final, but of course not the least speaker, Dr. Justine Lewis.
Hi, Hi everyone. Um, can you guys hear me? Yes. Hi guys. So I'm Justine. I apologize for being late. I just got out of the OR. But I am one of the CA2 or secondary anesthesiology residents here at Hopkins. A little bit about me. So I was born and raised in Trinidad and Tobago. I went to both undergrad and medical school at Howard, in DC. And I'm currently an anesthesia resident and will be pursuing a fellowship in obstetric anesthesiology, which I'll talk a little bit more about. I'm very passionate about mentorship, medical student education, as well as global health. So just a little bit about what an anesthesiologist is. So we are medical doctors, just like primary care physicians and surgeons. However, we specialize in anesthesia care, pain management, as well as critical care medicine. But the really cool and fascinating thing that I love about anesthesia is that we are required to have the knowledge of being able to treat the entire human body. Because when a patient comes to us in the operating room, we are responsible for taking care of the high blood pressure, the diabetes, and whatever other medical problems they might have, except under anesthesia, which sometimes can amplify certain diseases. Um, so very similarly, we have about 12 to 14 years of education. So undergrad, medical school, the total anesthesia residency time is about 4 years, and then specializing for us, our fellowships are about 1 year. Um, but we are responsible for evaluating, monitoring, as well as supervising patient care, both, well, I guess before, during, as well as after surgery. We deliver anesthesia in the operating room, as well as we lead the anesthesia care team. And the primary focus of our specialty is to ensure optimal patient safety. Um, so in terms of what anesthesia is in general, it's a medical intervention that is going to prevent patients from feeling pain during procedures like surgery, diagnostic tests, or even more simple things like dental procedures or skin biopsies. Lots of types of anesthesia. You can have general anesthesia, local anesthesia, or even regional anesthesia. What I'm particularly passionate about is more of the regional aspect and more so looking at obstetrics and helping women get through their pregnancies and deliveries safely. And some of those options are epidurals, which a lot of people may have heard about before, spinal injections, and really just getting them through that process safely. In terms of general anesthesia is more so going to affect the entire body. So that means that a patient is going to be completely unconscious. They're not going to be able to move or feel or respond. And most times I think when we think about surgery and general anesthesia, this is the type that we are thinking about. And surgeons really use it to operate on internal organs and for other invasive or time-consuming procedures, so things like back surgery. And without general anesthesia, a lot of life-saving procedures would not be possible. So things like open heart surgeries, brain surgeries, organ transplants, they kind of depend on general anesthesia. With respect to the local anesthesia, you can think about things that affect smaller parts of the body. So that's more like a single tooth or a skin excision or something like that. And then the regional anesthesia that we just discussed. So what I also love about anesthesia is that there are a lot of opportunities for specializing within the field. So like I mentioned, obstetric anesthesiology, which is what I'm going to do. You have pediatrics, so that's solely focusing on taking care of children in the operating room. There's anesthesia and pain medicine, so patients who have chronic pain can see an anesthesiologist who runs a pain clinic. Critical care, a lot of our ICUs here are run by both surgeons as well as anesthesiologists. That's our surgical ICUs. And we really get a lot of good training in terms of ICU and ventilation management. There is also cardiothoracic anesthesia, And that's, taking more so doing those kind of like big cases and heart transplants, things of that nature. Um, and then in terms of challenges that I overcame, firstly, being first generation, and coming from Trinidad, I came straight here into undergrad and into medical school. And there were a lot of different challenges that I had to kind of maneuver through. So one, just learning how a totally new system worked. Um, wasn't very easy, but I'm thankful that I was able to find good mentors and people that can guide me throughout the process. So that's something that I would definitely recommend doing as early as you can, because mentors will help you get to where you need to be in your specialty or whatever your decision is in terms of what you want to pursue. I'd also recommend finding mentors, not just in, exactly what you're interested in, but in different fields in medicine so that you can learn so much more. And then, I mean, I can also talk about failure because that's something that I had to overcome. One of the things that I didn't know about anesthesia was just how much board exams you have to take. So at the beginning of our the end of our first year of anesthesia, you have to take the first part of your boards, and I failed mine. But I was really, and I am very fortunate to be at a very supportive program like Hopkins, where I felt like I can talk to my mentors and the people in my program about the things that I struggled with during that time. And I never once felt that I wasn't good enough or smart enough to be here. So I think that's also important in looking for where and the type of program that you want to go to, making sure that it's somewhere that's going to support you and help you get to wherever you want to be. But I am very excited to be a part of this field. I'm very honored and humbled, really, to get to take care of patients in the way that I do every day. And I'm happy to answer any more questions anyone might have.
Thank you so much.